You sit there. It'll work out good.
But
If
every
you
time
like,
you touch the table,
Don't touch the table.
maybe I need to get my own table.
maybe. I can help you.
She's got to get her own table.
Yeah. She doesn't want to.
Is that too far away?
Thank you so much for being here tonight. Our East of Kansas City Mental Health Ministry, we're a collaborative team that is really trying to get mental health ministry going, support, care, awareness, and education on this side of the diocese. So I really want to say thank you for all of the team members that are facilitating, making this happen, and everybody that's been involved in getting us to this point. Tonight's presentation, we are blessed to have Dr. Janet Constance from the Veterans Administration Hospital, VA Hospital. I'll let you do the introduction, because you have so many letters behind your name. I wouldn't even know where they all been.
So what that means is I have a PhD, my specialty is talk therapy, and I've been specializing in PTSD for probably about 15 years now. Spending the majority of my career at the VA. But I also spent a little bit of time setting up Truman, who is now at University, is setting up their PTSD programs as well.
We are thankful to have you here. We're going to have all kinds of events. Yes?
Is there any way she can use the
I'll get a microphone. Yeah.
Yes.
I'll get a microphone before we start. But we're going to be hosting other events, but we're going to be doing it at other parishes as well. St. Mark's, St. John de Lawn, St. Jude. So before we get finished tonight, we have a sign-in sheet over here that if you don't mind putting your information, we're not going to hammer you with a bunch of emails, but just to let you know when different events are coming up. This is a very difficult topic, and it's one that a lot of people don't like to talk about. But many are affected by it. And those who suffer in silence because they don't know where to turn, and as faithful Catholics, sometimes we don't know how to respond to these things. So we're trying our best to get a grassroots effort to get this information out so we can begin to help people to heal. So we have a sign-in sheet if you don't mind signing in. We have a flyer to give you for our next event, which is going to be on Alzheimer's. My wife signed up for that. For some reason, I don't know why. That's one that affects a lot of us. So it's not just the people that are taking care of those who have mental health challenges. That's an extremely hard job. My wife can tell you, as somebody who's had to battle with the other side of caring for someone who's struggling. So it's hard to get people to come to these events, but we're thankful that you're here. So let's begin with a prayer, and then I'll gather the microphone and we'll get started. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Heavenly Father, thank you for giving us this opportunity tonight. Thank you for the humility with which everybody comes before to learn about difficult subjects and how to care and minister for those that we love. We ask that you send your Holy Spirit upon us and that you open our hearts and minds to receive whatever it is that you want to say. There's so much senseless suffering in this world, and you use us as your ministers to bring about compassion and support and accompaniment. So we ask you for all the graces that you can possibly send upon us tonight, that as we go forth, we can help to heal your world that you created for us. We ask that you bless Dr. Constance, that she has a clear mind, that she articulates well and says exactly what it is we need to hear. We will give you all the praise, honor, and glory, and ask for the intercession of all of our saints, especially Our Lady of Lourdes, as we pray. Hail Mary,
full of grace, the Lord is with thee. Blessed art thou among women, and blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners, now and at the hour of our death. Amen.
in the name of the Father, and the Son, and the Holy Spirit.
Amen.
That's okay, I'm going to talk loud while I was getting the microphone. So he mentioned this is a difficult topic, but I also think it's a really exciting topic because there are, PTSD is a very treatable condition, and there are really great treatments out there. So I'm hoping that I can get you guys excited about that as you head out in the world. I also wanted to say I'm very impressed by this group. This is a great turnout. So I think you guys have great things in front of you. So I have 4 main areas in mind for tonight. But as I go on, I'd love for you guys to be thinking about if there are that you had, like, related to PTSD that you had hoped to hear about, or burning questions that you had? Because I'm planning to leave a good amount of time at the end so that I can take those questions as well. So my plan tonight is to get us all on the same page about what is post-traumatic stress disorder. So we're going to take a look at the diagnostic criteria. We're also going to testing? Yeah. Okay, great. We're also going to talk about how to conceptualize PTSD, because I tell my vets all the time, in order to understand how to treat it, you got to understand how you got it. And then we're going to talk about an overview of the available PTSD treatment options, focusing on the evidence-based treatment options. And then I'm going to share with you guys lots of materials, educational materials, materials for loved ones and families, and people suffering with PTSD themselves, and also different ways to access care. All right, so I'm starting tonight with a brief little video. These are videos that I love. They're from the National Center for PTSD, and these are very brief little, like, just-in-time videos that can educate on PTSD. I think this one's just about 2.5 minutes. Yeah, that'll be good.
Have you or someone you love ever been in a tornado or car accident, experienced sexual or physical abuse, served in a war zone? Most people have been through some kind of life-threatening or traumatic event, and it's common to have stress-related reactions after a trauma. But when symptoms last more than 3 months and are not getting better, it's time to get help. Meet Sam. He recently returned from serving in Iraq. For many people, being in a crowded place like a baseball stadium or busy grocery store feels comfortable, but not for Sam. What should be a nice night out, taking his wife Tara to a restaurant, isn't fun for him anymore. He can only handle it if he sits with his back to the wall where he has a good view of the exits, and even then, he's too on edge to really enjoy it. At home, things aren't the way they used to be either. His sleep is restless at best, and some nights Tara isn't sure if Sam comes to bed at all. Sam seems to have a short fuse these days, and sometimes he snaps at Tara over tiny misunderstandings. What he and Tara never talk about is the trauma he experienced when he was deployed. He's never mentioned the guilt, the weight he carries around, wishing he could have done more to prevent what happened. Instead, he's turned inward, pulling away from family and friends. Tara tried to give him some space, but after months passing without change, she really started to worry. She was the one to finally say what they were both thinking. It's time to get help. That's when Sam finally decided to take action. He reached out to a doctor who told him about PTSD, or post-traumatic stress disorder. Sam's symptoms were getting in the way of enjoying his life. Were you experiencing hyperarousal, feeling worse about yourself or the world, and avoidance are the 4 types of symptoms people with PTSD have. Sam's doctor explained each. The first is reliving the event, or re-experiencing. This is often an unwanted memory or even a flashback when you feel like you're right back in the situation again. Seeing, hearing, or even smelling something that reminds you of the trauma can trigger these. Nightmares where you relive parts of the event in your sleep are common too. The second is avoidance. Staying away from situations that remind you of the trauma. That's why Sam tries to avoid thinking about painful memories altogether. He pours himself into his work, or uses alcohol to keep his mind from going back to the trauma. The third is feeling worse about yourself or the world since the trauma. You might feel overwhelming guilt, like Sam, or not trust anyone. You just might not be able to feel happy, even when you're around people you love. The fourth type of symptom is sudden rushes of anger, irritability, feeling jittery, always on alert, always on the lookout for danger. This is called hyperarousal, and loud noises or a driver coming in front of you can be all it takes to set you off. If you recognize any of these symptoms of PTSD in yourself or someone you love, don't wait. See your doctor to find out if it could be PTSD. Just like Sam and Tara found, there is hope. You don't have to live with the symptoms of PTSD forever. effective treatments are available. To learn more about PTSD or how to get help, visit the National Center for PTSD website at www.ptsd.va.gov.
Okay, so I think that's a nice video to kick off our conversation tonight. I frequently show it to my veterans, if they're pretty new to the diagnosis, and we're just getting kind of an overview of what that's about. And I find that it really helps with treatment buy-in, because they watch the video and they're like, so what were your thoughts? They're like, yeah, that's me. So I think it's just a nice way to get that overview. So in terms of the diagnostic criteria for PTSD, I'm going to actually pull back for a second. PTSD is an anxiety disorder, and there are many different types of anxiety disorders, but PTSD is the only one where you have to have a prerequisite, and that prerequisite is a certain type of trauma that would kick off this reaction. Without the trauma that's associated with symptoms, you're very likely looking at a different anxiety disorder, and there are many different types, like generalized anxiety, obsessive compulsive disorder, just to name a few, panic disorder. So in my role, we call this criterion A, and that's according to the DSM, or the Diagnostic Statistical Manual, and we're on number 5 now. And so according to DSM, the traumas that tend to cause PTSD are pretty specific in nature. You have to be exposed to actual or threatened death, serious injury, or sexual violation. So really something where your actual physical integrity is threatened. So the person can directly experience that themselves. They can witness in person the traumatic event occurring to other people. They can learn about the traumatic event occurring to a close family member or a close friend. In cases where it's actual or threatened, a death of a family member, they really feel that it needs to be something that was violent or accidental rather than a natural passing, that sort of thing. And this is newer. They really recognize the kind of trauma that first responders go through. So experiencing repeated or extreme exposure to adversive details of traumatic events. So first responders collecting human remains, or police officers repeatedly exposed to details of child abuse. And they make a note that those exposures, they don't apply if they're through electronic media or television or pictures, unless the exposure is work-related. So after you establish that they do have a trauma that meets that criteria, then you have to establish there's a connection between that trauma and the symptoms that they're having. And with PTSD, there's 4 main symptom clusters. So the first one we call criterion B. We used to call this re-experiencing, now they call it intrusions. But the idea is that they re-experience or re-encounter the trauma in some type of way. So it could be recurrent, repeated, disturbing, and unwanted memories of the past stressful experience. So this could be images, that sort of thing. It could be repeated, disturbing dreams. They could also have the experience where they have dissociative reactions. You might have heard it referred to as a flashback, which is a very vivid recollection of the trauma that is so vivid and intense that it actually feels like they're back there, actually reliving it. So we would say, are you suddenly feeling or acting as if the stressful experience were actually happening again, as if you were actually back there reliving it? And there's kind of a continuum of that reaction. So sometimes I'll hear people say, someone came up and tapped me on the shoulder, and just for that second, I thought I was back in the alley, with the attacker. Or I was in the car, and the sun just was beating down on my arm in a certain way, and I went to go look for my sidearm because I thought I was back in Iraq. So it can be just that momentary slip, all the way up through some of the dramatic stuff you might see in the movies where they completely lose track of where they are. Maybe they're low crawling on the ground as if they're back in Vietnam. The more intense, the more prolonged, the more rare that it is. Another way that they can re-experience is by having, feeling very upset that by avoiding memories, thoughts, or feelings related to the trauma. Or they could avoid external reminders of the trauma. This could be people, places, objects, situations that are reminders. You only need one of those, but typically you're going to see both. And then criterion D is actually newer than some of the latest additions. But they decided that you kind of see this cluster of changes, negative alterations in cognition and mood. So there's, I think there's about 7 needs. You only need 2. And so it could be that there's like dissociative amnesia. This is probably one of the least endorsed symptoms of PTSD, but it happens when there's like unexplained gaps of time missing in their memory. So for instance, somebody who's trapped under a burning vehicle, their brain might involuntarily dissociate, right? Disconnect from that. And so when they try to remember it later, it feels like that memory is not there. Mostly people will say, I remember every detail and I wish I could. They also can have persistent and exaggerated beliefs about the world. So these tend to be slanted in that negative way. So they could be about themselves, the world, or other people. Tend to be clustered in the areas related to safety, trust, power or control, maybe even self-esteem or how they feel about other people, and intimacy. Or some of the main areas that you'll see that. Some of the examples we'll give is, yeah, I am bad. There is something seriously wrong with me. No one can be trusted. The world is a completely dangerous place. Persistent, distorted beliefs about the cause or the consequence of the traumatic event is also very common with post-traumatic stress. So think inappropriate self-blame or inappropriate blame of other people. Then you get into persistent negative emotions. Fear, horror, anger, guilt, shame. Their emotional lives tend to be dominated by these very negative, intense experiences, and they often have trouble experiencing positive feelings like love, happiness, satisfaction. In fact, someone just today said, "Man, I had this great thing going on, and I just didn't feel any happiness about that at all." And that was just very classic PTSD. Let's see. So diminished interest or participation in significant activities. We call that anhedonia, or not just lack of interest in things. That's going to be a major overlap with depression as well. And feeling detached or estranged from other people is also very common. So that is criterion D. Again, you only need 2 of those. Criterion E is really, we think that is the increased arousal or hyperarousal. Irritability, angry outbursts, acting aggressively, being reckless or self-destructive, hypervigilance, exaggerated startle response, problems with concentration, and sleep disturbance. You can see those are all things that are related to this just general being really keyed up, agitated, jumpy, jittery, restless, that you see with anxiety disorders and post-traumatic stress. So those are kind of the 4 main symptom clusters. And if I'm having that right, you could get out of that with only having 1 in the first cluster, 1 in the second, 2 in each of the following, right? So you could be on the low end of things. Mostly people are going to endorse 17, 18, 19 of those symptoms. The duration has to be at least 1 month. So by 1 month, we would have expected that natural recovery would have kicked in and we would not still be seeing symptoms of this severity. So already by 1 month post-trauma, we're going to call that acute stress disorder. And we go ahead and name it at that point because we want our eyes on it. We want to be very aware of what's going there and we can track it. By 3 months post, you're already in chronic PTSD. And in 3 months post, you meet criteria for PTSD. The research shows that you will continue to meet it at a year unless you get some pretty dramatic intervention. So really, once PTSD takes root, it is really very self-sustaining. And what the research shows is it actually works over time. So that's a common question I'll ask my patients. I'll say, is it worse for you today than it was a year ago? Yeah. What about 5 years ago? Oh yeah, this is the worst it's ever been. And that tends to be that every day it just kind of get further and further embedded in this stuff. For any disorder, it has to cause clinically significant impairment or distress, and it's not going to be attributed to a medication or alcohol or other medical condition. There are some subtypes of PTSD I wanted to throw in. I forgot to add. I'm presenting the criteria for adult PTSD. The criteria for child PTSD just looks a little bit different, but really it's very much the same things. There are some subtypes related to dissociative symptoms. So while anybody with PTSD can have some dissociation, if someone has a significant amount of that, we're going to want to note it in a subtype. It might influence the types of treatments we pick. And there's two different kinds. It could be depersonalization or derealization. There's actually a delayed expression specifier as well. So the classic example they'll give is, let's say there was a woman who was sexually assaulted. And coming out of the assault, she ends up naturally recovering and does well, has a lot of support. But then a year later, she learns that the person who had assaulted her actually ended up killing his next victim. And she might then start to have a post-traumatic response based on this new information, all right? Because all of a sudden now it's that actual or threatened death. I wanted to talk to you a bit about PTSD assessment. I'm going to go really light on this because it can get pretty thick. But basically, with PTSD, there are screeners. So these would be really brief measures where the goal would be to cast a wide net and hopefully catch a lot of people that we could then further screen for rule out PTSD. There are also self-report measures. So these would be things that people would fill out on their own based off of their experience. That would typically be used during an assessment as that additional piece of information in addition to our assessment. Those tend to overlap with the outcome measures. So those would be measures that they would give you while you were in treatment to make sure that the treatment is working and that you're improving. So recovery. Meaning that we would expect that natural recovery will kick in. It does for the vast majority of people. So research suggests that at any given time, 60 to 70% of us have been through something that would meet criterion A for a PTSD traumatic event. But most of us don't go on to get post-traumatic stress. The lifetime average might be around 10 to 15%. So in my line of work, we spend a lot of time saying, what is the difference between these two groups? People who seem to be able to naturally recover and get back on life, and the people who seemingly get stuck in their recovery and go on to develop post-traumatic stress. I mentioned natural recovery several times, so it's interesting that immediately following the trauma, and then hours, days, weeks following the trauma, the symptoms that we typically associate with post-traumatic stress would just be straight up normal. So if I, hopefully not, but when I'm going down in a severe car accident tonight, I might have a nightmare about it tonight. I might be feeling jumping if I'm on edge. I might try hard not to think about it. I might be more irritable. I might have trouble sleeping tonight, right? All of those would be pretty normal. And initially, post-traumatic stress reactions are thought to be helpful. That thinking about the trauma can help me process it. It can help me work through it, make sense of it, gain new perspective, maybe make peace with what happened. And so initially that's helpful, and as the survivor makes sense of it, the emotions and the acute reactions from the trauma become less intense. So again, you're already starting to see this within the first few days, weeks. By the time you get up to a month, we're already thinking, this is not heading in a good direction. We would have expected by this point that things would have begun to calm down. So the research very clearly shows two things that get in the way of natural recovery. One is avoidance, and one is the development of unhelpful thoughts and beliefs that stem from the trauma. So any good treatment is going to target both of those, because our goal is to get those two things out of the way so that natural recovery can begin. So when I talk about avoidance, there's kind of two main ways that people avoid dealing with trauma reminders. They'll either try to push away those memories, those thoughts, those feelings about the trauma, or they'll try to escape and avoid situations, places, people, things, objects, activities that are reminders. And typically they're going to do both of those, right? Because they're doing everything they can to try to stay afloat during this really difficult time while they're trying to manage this. And initially, avoidance, it actually works really well in the short term. So you can imagine just like a daily life example. Let's say I'm having a fight with my husband this morning. I'm all worked up about it, so I gotta go to work, right? Distracting myself by thinking about something else and getting that off my mind is likely to help me feel better, right? So in the moment, my brain is like, oh, that's pretty good. Avoidance, that works pretty well. And when your brain learns a strategy that feels helpful, it's just going to keep going back to that. So someone with post-traumatic stress typically develops a very addictive cycle with avoidance, where they just tend to use avoidance as their main coping strategy. I sometimes will joke with my folks and say, if I was going to teach a class on how to avoid, you would be my guest lecturer. Because they are experts. They do things that I just never even thought about or imagined. I literally learn new ways to avoid every day. So how it works in the short term, and in the long run, what happens is that it interferes with their recovery, right? It actually ends up prolonging their post-traumatic stress reaction. Another way to say it is it maintains it over time. Because if you don't think about it, you don't talk about it, you don't have feelings related to it, you don't have an opportunity to process it, right? And you get stuck. And if you don't expose yourself to things that make you feel anxious and end up getting used to those and building them back in your life, then you end up stuck feeling like you have to avoid. So those are kind of the two main ways that avoidance gets people stuck in their recovery. And then at the same time, you've got these unhealthy thoughts and beliefs that kind of kick off around the time of trauma, and they are just further like cemented by the avoidance. So let me give you an example. Let's say I have a trauma, let's say something terrible happened to me at Walmart. That tends to be the most feared place on the planet, by the way. People like in Walmart, the crowds, the chaos, the people, right? And so let's say I had something traumatic happen at Walmart, I trip over something, and I get injured very badly when I'm there. So it's pretty normal, but I might start thinking, Walmart is a dangerous place. I don't want to go there, right? And I don't want you to go there either. And we're going to really start to build things around. We're just going to go to Target instead, right? And so I continue to avoid. So what happens is I never get an opportunity to debunk that idea, right? I develop this pretty extreme unhelpful thinking, and I never get a chance to prove myself wrong. So you can see how the avoidance in itself starts to actually maintain this unhelpful thinking as well. And then the unhelpful thinking furthers the avoidance. So they just really start to work together, and you can imagine a snowball rolling downhill, and it just starts picking up speed and momentum. So as I mentioned before, these unhelpful thoughts and beliefs, they can be about their understanding of why the trauma happened. So you might think about a lot of, I should have, I could have, well, I would have, if only, right? And that can lead to a lot of self-blame. And it's really sort of interesting how that line of thinking works, right? Because the person's trying really hard to figure out, how can I not encounter this again, right? How can I keep myself safe in the future? And so in some ways, it's easier to believe that I'm to blame for what happened, but also get to believe that I can just fix things and I'll be safe. Versus believing that the world is a chaotic, unpredictable place, and sometimes dangerous things happen. Sometimes that's a harder pill to swallow. So in that way, it might be easier to blame yourself and get to believe that you can, if you can just change things, you can just fix things, if you can just figure out what went wrong. Just today, I had an in-depth conversation with someone. He said, I should have known this or that. And we talked to death, and in the end, he's like, yeah, there was literally no way to know, right? But he's like, I just want to believe that there could have been, because, I want to be able to prevent this in the future. They're very common. So but these thoughts, right, they're extreme, they're unhelpful, they tend to be excessively negative and overblown, overgeneralized, and they just interfere with the person getting back to life. And so in that way, they end up interfering with that natural recovery, because getting back to life is what really helps people with PTSD recover. Okay, so anybody have any questions about how PTSD develops or how it's maintained? All right, I'm going to talk about this a little bit more as we get into talking about PTSD treatment options. At the VA, hopefully psychology in general, we're very focused on treatments that work, treatments that are researched. And so for PTSD treatments, we've got a lot of knowledge about the treatments that are most successful for us. I'm going to let the video give you an overview, but I'm going to talk a little bit more about it. In general, we're going to be looking at talk therapy options and medication options. So this is the National Center for PTSD website. This is my holy grail. I come here every day. And I'm going to show you. Let's see, I'm here. Here we go.
So, you've been diagnosed with PTSD, post-traumatic stress disorder. You might be thinking, does therapy for PTSD really work? Or what about medications? Well, there are treatments that work and you have choices. We're going to show you PTSD treatments that are evidence-based, which means they've been proven to work in multiple scientific studies. Two of the most effective PTSD treatments are cognitive processing therapy and prolonged exposure. Both are cognitive behavioral therapies, CBT for short. CBT is far from just talking. You'll learn skills to manage your PTSD symptoms. Cognitive processing therapy teaches you how to change negative thoughts feel. Prolonged exposure helps you confront memories and situations you've been avoiding since your trauma. This gets easier with time, and eventually you won't need to avoid them. Another effective therapy is EMDR, which involves thinking about images and feelings that distress you while doing rapid eye movements. This can help you change how you react to trauma memories. Therapies like these usually take 3 to 4 months of weekly visits, and improvement can last for years. Medications are another effective option. The best medications for treating PTSD symptoms are antidepressants, specifically SSRIs and SNRIs. Antidepressants work by helping brain cells communicate better, and that can make you feel better. Improvements in your PTSD symptoms will last for as long as you keep taking it. You might have heard about benzodiazepines or benzos. In the past, doctors prescribed these anti-anxiety medications for PTSD. New research shows anti-anxiety medications may interfere with therapy and do not improve PTSD. These medications can also lead to harmful side effects like confusion, fogginess, and accidents or falls. If you're taking benzodiazepines or other medications with potentially harmful side effects like atypical antipsychotics, talk to your doctor about whether you should safely stop them. There are more effective options for PTSD. It's common to have other problems at the same time you have PTSD, like chronic pain, depression, substance abuse, a history of traumatic brain injury, or insomnia. Often treatments effective for PTSD can help with these problems too. In other cases, your doctor might suggest an additional treatment. For example, there's a special type of cognitive behavioral therapy called CBTI. The I is for insomnia. CBTI teaches you skills that can improve your sleep, even after just a few therapy appointments. Some antidepressants can help with sleep too, and there is a medication called prazosin specifically for nightmares. So, where do you start? Talk to your provider about which effective treatment options are right for you. Therapy, medications, or maybe both. And remember, it's always important to talk to your doctor before stopping or switching medications. For more information, visit the National Center for PTSD website at www.ptsd.va.gov. To find a mental health provider, click the Get Help for PTSD button, or see success stories at About Face.
So this is the PTSD treatment decision aid. This is really cool and interactive. So under the learn section, it talks about how the decision aid works and how it introduces you to the tool, but it also gives you the basic information about PTSD. And then you go to the compare section. And it has what I want in the treatment. And so you, as a patient, you can actually go through this and talk about what kinds of things that you would want in the treatment, and it helps you decide what treatment might fit best. So like the first one, it's asking you what are your thoughts on medication versus psychotherapy, and then it even tells you what others said, and you can look at what other people with similar issues might have said as well. They show you a comparison chart about what works and what you do in it and what it involves. I think there's like 6 questions here. So I ask you, do you want to talk about your trauma? And then what's really neat is they say, you want to hear what it's like to talk about your trauma from other people with PTSD. Is that there's short little videos, there's descriptions going on. So I think that's a really neat option. And then once you finish that quiz, it will take you to it'll actually say, this is what we think is the best fit for you. And then it takes you to this comparison chart so that you can look through and actually see what your options are. So, across the top, that's where you see cognitive processing therapy. And you notice in that one they said, we're going to be focusing on your unhelpful thoughts and beliefs, right? Because that's one of those things that gets in the way. And then prolonged exposure said, focus on your avoidance first. So both treatments are going to end up doing both things, but you've got to get your foot in the door somewhere. So one starts in one area and one starts in the other. And then you've got that treatment called EMDR, and then you've got medication. So what's really neat is in each one of these boxes, you've got videos that you can put on and videos to look at. And they tell you, is it effective? You can actually look at the research related to what treatments work. So this is just a really neat tool. And they talk about risks, the benefits, do I have homework, where is it available? Do I use inadequate this treatment? And then you can go down to your treatment preferences here. And this is where you can kind of learn what you're interested in. And then there's an act section. So it talks to you about how to talk to the provider, different steps, what to do. So I think the PTSD treatment decision aid is really neat. If I'm having a treatment planning discussion with someone, generally my style is I'm going to make a recommendation that I think might fit them best. But if they're kind of unsure or we need more time to talk about it, then I'll send them home with this and have them explore it and then come back with their questions and their thoughts. And that's always a nice way to start the conversation. Okay, so you're working good here. And there's my presentation. Sorry for that. On the National Center for PTSD, they also have an entire section about the different apps that are available for PTSD. So actually, I jumped ahead of myself. This is a picture of the PTSD, the National Center for PTSD website. They've got lots of options down the side, tons of educational materials and videos and links and just a lot of really neat stuff. So we'll get some time to look through that. Okay, so here are just some things that I thought were maybe the highlights for this group. As I mentioned, we've got lots of educational material, but there's also sections on how to get help if you're in crisis. So there's a new Veterans Crisis Line number, which is 988. And actually, it's the crisis line number for everybody. And you push 1 if you're a veteran, and it kind of routes you that way. But also how to find a PTSD treatment provider. They have lots of resources there. Information for family and friends. I was looking for this last night. They used to have the cutest little collaboration that they did with Sesame Street about deployments and about PTSD. I couldn't quite find it last night, but apps, videos. So we go for that. And then we mentioned the mobile apps as well. So there's going to be some mobile apps that are really designed for self-help. There's going to be some that are designed to be used along with the treatment. And there's going to be some that are really designed for like even friends, family members, symptom monitoring, symptom management. So there are lots of different options there. And then in terms of the whiteboard videos, these ones I've been showing you with the drawings, there are lots of different topics there as well. So I listed them, and when I posted them, these all look right like the videos, but we had some trouble getting the hyperlinks to work. So I it increases your chance of finishing the treatment by 20%. So just because you have more of an idea of what to expect, they talk to you about some of the tough things, but also talk to you about some of the potential rewards in a way that I, as a provider, maybe you're not going to speak the same language in that way. Okay, so there are your mobile apps. So I'm going to just get PowerPoint and show you those websites. National Center for PTSD. Okay. Here's the about face. So you could go to that video section.
Is that also a VA or is it not governmental?
I'm pretty sure it's a VA. VA has a lot of money to throw towards these things, so they tend to all be sponsored by. Yeah, it's called About Face. There was another one called Make a Connection, and that was more general and related to mental health topics other than PTSD. This one is very focused on PTSD. So many topics that you could explore, videos you could watch. I did want to highlight to you guys that you can pick these different sections. So you can apply different filters, different topics, who's being interviewed. So pretty neat stuff. All right, so that is all the material that I had planned for you guys tonight. So I really wanted to open it up to some questions. Yeah.
What are the most commonly used medications to treat PTSD?
It tends to be SNRIs. As the video mentioned, they were really bad in the past about freely prescribing benzodiazepines. But the research really quickly shows that not only is it not helpful, that it's actually detrimental and it can cause additional problems. So I haven't seen benzos prescribed in a while, which is great. Typically, we don't see a lot of antidepressant medications. And sometimes you'll see the treatments that they prescribe for anger suppression, which tend to be like blood pressure medications. But they find is if they can lower your overall level of physiological arousal, that the nightmares are less likely to break through your mental level. We still have them, but kind of like if the tree falls in the woods and no one's around to hear it, they really make a noise. If you have a nightmare and you don't wake up and realize, it's less likely to cause distress. Yeah.
I had a theory that most people wandering around have some level of PTSD, but most people don't have some violent trauma, but most people have traumas in their life, whether it's a death or a whole list of them, but they don't call it PTSD. But the answer seems to be the same path that you get on.
Yeah, so we'll talk about big T and little t, right? Big T are the types of traumas that I told you about, those criteria A traumas, the really heavy-hitting ones. Little t are, like you said, the daily life traumas that we all go through. And those are the types of things, adversities, maybe you could call them, different things like that, that those could cause any number of mental health concerns. So they could kick off a bout of insomnia, they could cause a major depressive episode, they could cause another anxiety disorder. Well, that's the way we'll look at that.
But again, sometimes you don't get over it. So then, if I'm hearing what you're saying, if somebody doesn't get over it after a month or so, it really does get into PTSD. But you're saying that it could be small t SD?
Yeah, so like a small t trauma, like you said, we could give any number of things that could cause that, right? Maybe a divorce or something like that. And so it's not uncommon, right? After a stressor like that, or a loss of a job, or a loss of a loved one, right? Death of a loved one. And you could go on and develop a different type of anxiety disorder that might look similar to PTSD, except that it wasn't caused by a big T trauma, and that you don't
mentoring from other places, and they actually saw that there was a small